Good afternoon, everybody, and thank you for joining for the Asthma Training Series, session number 2. This is 2 of 3 sessions for the Asthma Training Series. Thank you all for joining again. We are happy to be working with ODH on this training series for asthma. Next slide, please. Thank you to our program partner, the Ohio Department of Health. And to your slide. Today's presenter, we'll be hearing from Dr. Elizabeth Allen, who is a mostly retired Nationwide Children's Hospital pediatric pulmonologist, whose career included the treatment of children with challenging asthma and the implementation of multiple quality improvement efforts to improve the care of asthma children throughout Central Ohio. She currently serves as the medical director of the NCH School-Based Asthma Therapy Program, or SBAT. Dr. Allen, thank you for joining us today.
Thank you for having me. I'm excited to talk to everybody today about some of the things we've learned about working with schools in the setting of our school-based asthma therapy program. But I really want to do this within it. This is sort of, we'll get to this eventually. What I really want to do is talk about improving asthma care overall for our outpatients in particular. And in part informed by my experiences leading the asthma quality improvement team at Nationwide Children's for about 10 years. Over that period, we were able to drop emergency room rates use by our Medicaid patients by about 30%. And we even saw that drop happen specifically within the primary care network around some interventions that we use. So I'd like to use this talk to talk about in general improving asthma care, and then specifically how we can incorporate our schools with that. So I have no financial relationships to disclose, and if anyone has any feedback about how this might be presented in a better way for diversity, equity, and inclusion standards, please let me know, and that's my email address. So again, roadmap. I would like to start with just talking about some key components of high quality asthma care, some challenges to providing this care, and I'm not going to spend a lot of time on that because I know all of you are very familiar with those challenges. Some office strategies around tackling those challenges, and then work into how partnerships with schools, and particularly school nurses, can be helpful in advancing this kind of excellent care. So just to kind of run through the key issues with quality asthma care, of course, first it's going to be to correctly recognize the condition. And I'm sure that a lot of this is going to be review for you folks, but asthma enters our differential when we're having often recurring ebbing and flowing sorts of symptoms, but also chronic symptoms that involve coughing, wheezing, and or shortness of breath or chest tightness. Now, our suspicion that asthma is involved with those symptoms is going to go up if those symptoms are occurring in the time that typically events that trigger asthma. So if they're occurring in response to exposure to allergens or to exercise. For some kids, the weather changes suddenly. For many children, the most severe episodes happen in the setting of an upper respiratory infection. But if the symptoms are coming in conjunction with those sorts of events, your suspicions are going to go up. If there's a personal or family history of atopy or asthma, your suspicions are going to go up. If you are able to get pulmonary function testing that shows obstruction, and particularly if that obstruction resolves after administration of short-acting beta agonists, that's as close to we have as an on-paper test to sort of prove asthma in this setting. Unfortunately, in pediatrics, we have a lot of issues around kids having difficulty doing these tests correctly or catching kids when they do have a little bit of obstruction. Many children with asthma, even fairly severe asthma, may walk around on an average day with normal PFTs. So this type of testing can be really helpful to catch folks who are underestimating the severity of their asthma, or occasionally to sort of be a proof on paper of the diagnosis, but it is not necessary to clinch the diagnosis in children. More often, we're looking for a clinical diagnosis. We can talk about looking for improvement, just as in PFTs, where it's a for sure kind of thing if you see a response to short-acting beta agonists. We can also ask about whether symptoms improve in response to asthma medicines. And here I would encourage you to ask questions that clarify whether the symptoms improve in a time frame that you would expect for the illness. For example, I had kids come into the office who, when you asked, did they get better with that albuterol I gave them? The answer is yes, but with an added comment after I'd given it to them for 4 days. Well, that's not the pattern that you expect with asthma, right? What I would more expect to hear is, yeah, but then their symptoms came back later that day, which would be more the expected pattern. So you want to see that timeline response to SABAs. On the other hand, in corticosteroids, I would not expect to hear that it immediately made them better. Usually you're going to trial ICSs in situations like chronic cough or something where the diagnosis is a little unclear, but there you need to give it a good 2 to 4 weeks before you decide whether it's working or not. Finally, as you're thinking through, am I going to dub this child asthma or not, or go forward with, making that my working diagnosis, you also want to be sure that there's no red flags. So examples of red flags would be, certainly failure to thrive, wheezing that is intractable and occurs with, sort of relentlessly day in and day out. Asthma wheezing is usually more intermittent and again, responsive to therapies. Problems like clubbing, that sort of thing. Any of that is going to be an issue where you're going to want to rethink the diagnosis. As sort of an addendum to that, the 4-year-old age group, while they definitely are 4-year-olds who are in the early stages of having asthma and respond to asthma therapies, and that's the way to go. This is also a age group where you have to approach it with a little extra humility. These very young children are the children that can present with wheezing related to congenital airway abnormalities. This is the age group that manages to get foreign bodies down the wrong pipe that might lead to wheezing. This is also the age group that I think we more commonly bump up against, those kids that only wheeze with viral triggers. And while that looks all the world like an asthmatic reacting to a virus, they're not very responsive to our therapies, but happily they often outgrow this tendency as they get into school age. So yes, we absolutely diagnose and treat asthma in the under 4s, but you just have to approach it with a little humility as you work on those. Much of what I'm going to be talking about, by the way, as we go forward in this talk, will be the older kids, 5 and older, with some nuances that do come into play with the under 4s, particularly which medicines are approved. ICS LABAs aren't for that age group. And if we have time, we can circle back with any questions about that. And oh, by the way, if you have questions, do go ahead and type them into the chat. I'm going to hold them, though, until the end of the talk, and then we'll tackle them. So back to key components of quality asthma care. The next thing you want to do once you've decided the child has asthma is do an accurate assessment of their impairment and risk. These terms simply imply that you're going to talk about how much is asthma affecting them on a day-to-day or chronic basis. And also, how much are they having severe episodes that put them at risk for badness? And usually a severe episode is defined as anything that doesn't respond to beta agonist therapy and requires addition of an oral steroid. And these two don't always go together. There are some kids that have a lot of impairment but don't seem to sink into bad episodes all that often. There are also children who can be in the hospital 2 or 3 times a year and in between seem fine. And we want to know about both of these issues as we decide how to categorize folks, both regarding their severity and then which is kind of implies how bad their asthma is when you're first seeing them and trying to decide how much medication to start them on. And also their control, which implies they're already on a path and you're trying to decide whether it's the right path or whether it's working for them as it should. I know Kellen's, there's a number of different charts that are split up by age groups. This is a condensation of that I think Kellen shared with you last month that I kind of like. It gives you the concept of we have kids who range from intermittent, which means they don't have symptoms very often. They don't get in bad trouble with their asthma. And it may be perfectly reasonable, especially by US guidelines, to treat them just as needed with albuterol, all the way up to children who have very persistent symptoms or very dangerous episodes, and then different levels of severity in between. I like sort of focusing on this mild persistent column because it's really the break point between when we should consider adding a control, or anybody who's got persistent asthma ought to be on some routine prevention therapy. And it's also the column that you're going to be kind of asking the same questions along this line when you try and decide whether the patient's in good control or not. And I really like the rule of two sort of approach to this, as opposed to memorizing the whole table. You know, are they having symptoms more than twice a week? Are they using their rescue medicine more than twice a week? Are they waking up at night due to their asthma more than a couple times a month? Or are they needing steroids more than twice a year? Yes to any one of those questions, or to the questions, does asthma interfere with your ability to run and play and do things, is enough to say that they have at least persistent asthma, and or that they're not in control with however you're approaching them at this moment. Notice that pulmonary function testing at this level would still be interpreted as normal. And if you have somebody you catch with abnormal PFTs, you're already categorizing them as moderate persistent, regardless of what they're telling you about the rest of their symptoms. So once you've got an idea of the patient's impairment and risk, then we get into prescribing effective therapies that are scaled to their asthma severity and level of control. And here's where there have been some changes in recommendations that are new since 2020. What hasn't changed and remains kind of a golden rule for asthma is that inhaled corticosteroid therapy remains the backbone of how we approach these patients. It is by far and away our best controller monotherapy when it comes to achieving control, reducing impairment. It's the only drug whose use has been connected to reducing the risk of death from asthma. So anybody who has persistent asthma should be taking at least a low dose of inhaled corticosteroid. Unfortunately, although, you know, we'd love to have this drug be something where you could just titrate up till they got in control and we were good to go, it turns out that in increasing the dose of inhaled corticosteroids for patients sometimes is helpful, sometimes it isn't. Kind of depends on the child. And it's also true that as you crank that dose up, you do start to slide into arenas where you may see some side effects. And in kids, we're particularly concerned about watching impact on linear growth, and much less commonly on adrenal function. But either way, as you push into higher doses, you do need to be aware that those are potential things to be concerned about. That fact is why, you know, traditionally, once we have a patient is not adequately controlled on low-dose ICS therapy, we have a number of options about what to do next. We could try doubling the ICS, and in fact, that's what's recommended in those less than 4-year-old kids. But we also might try adding Montelukast or Singulair, or adding a LABA. In the old days, it wasn't really clear which one of these was the best way to go. And the recommendation was you would just try one or the other, kind of depending. And if that didn't work, you could flip to the other. Of course, we've had some new issues sneak in regarding side effects with Singulair. It now has a black box warning over its potential effects on neuropsychiatric symptoms, anything from bad dreams to even suicidal ideation, very rarely, but you need to be aware of that if you're going to use that approach. Between that and also things we've learned about the efficacy of ICS LABA compared to these other combos, there has now been a shift in the new guidelines to say we really do have a preference. And that preference is if you're not doing well on low-dose ICS, your next step is to an ICS LABA. Again, that doesn't include the under 4s. So this is an example of one of the tables, and you can see that there's a link there where you can get the update with all the different tables that I'm showing you that focuses on, again, the concept that you're going to use as needed short-acting beta agonist, I'll say albuterol for that, for their intermittent asthma. And then once you're into persistent, even the mild persistence, you're going to use a low dose of ICS. But once that's not working, all of those next steps involve using a combination of an ICS LABA. And what's even more, some people call revolutionary change, has been that we're also going to talk in step 3 and step 4 when we're using low to medium dose ICS formoterol, that we actually use that in the SMART therapy approach, meaning that for the first time in many, many decades of care, we have something different that we're going to do to approach acute asthma. And instead of knee-jerk using albuterol, there are patients that are better served by actually having them use their ICS formoterol medication as their rescue. Now, you guys have been, I'm sure, hearing about this SMART approach, single maintenance and reliever therapy. This is now recommended as of 2020 by the NHLBI and AEPP group in the United States. GINA, the Global Initiative for Asthma, has actually been recommending this approach for the moderate patients, like we're doing now in the US, for over 10 years. And their most recent recommendations, based on they meet yearly to do their updates, not every decade or two, their most recent recommendations are actually expanding the recommendation for SMART out into even for kids who have intermittent asthma, and certainly for kids with mild persistent. I bring those up not so much to push that we take that approach at this point, but just to give you an idea of where the literature is going and why it's important that you really start to kind of think through and get used to potentially using this kind of approach. Why are these recommendations coming out? Well, because there's been a lot of studies done, including good RCT studies that folks put a lot of value on, that show that if you've got a kid who is failing, low-dose inhaled corticosteroids, and you're doing that step up to either an ICS-LABA or doubling your ICS, that they will do better if they also use their ICS-LABA, if they're an ICS-LABA SMART therapy approach will do better, particularly in terms of keeping kids out of the emergency room and off of the steroids, those dangerous episodes, than either of these approaches. That the SABAs, that adding that inhaled corticosteroid as an added anti-inflammatory during acute symptoms makes a difference in cooling things off better. Now, it kind of makes sense that this would work for a number of reasons. One is that when you're flared up, your inflammation is worse. So dosing with a little inhale extra ICS makes sense. But also this eliminates some of the confusion that our families have regarding which inhaler they're supposed to use when. And we run into this confusion a lot with our patients, and I imagine you do too, where they're grabbing the wrong inhaler. And particularly, honestly, as insurance companies have made us switch back and forth between controllers and whatnot, our asthma education folks will go out and find folks with drawerfuls of multicolored inhalers that they've accumulated over time, and it's no wonder that folks get them confused. This way, it keeps it simple. You have one inhaler, and that's what you're going to use, whether you're having symptoms or for your daily use. The other thing that this does is recognize that many, if not most of our patients are not terribly consistent with their day-to-day controller use. This automatically makes them ramp up controller use just as their symptoms are sliding out of control, which again helps get them back under control. There are, just to re-emphasize, there's a lot of different products out there that involve this combination of ICS-LABAs. The only ones that work for this SMART therapy are ones that contain formoterol. Formoterol is that LABA that actually kicks in quite quickly within a few minutes, similar to albuterol, as opposed to the other medications that have ones that don't start working for a longer period of time. And also the recommendation is that in the United States that we use this with ICS-LABA combinations that involve low to medium doses of your inhaled corticosteroids. And so the highlighted ones there are the ones that you can use for a SMART therapy approach. One of the pushbacks that you may hear about in terms of using SMART therapy is the worry about FDA labeling not matching this approach. This is a screenshot of the FDA label for Symbicort, and it actually even says Symbicort should not be used for acute asthma symptoms, basically. I've highlighted why they say that, and the explanation given is simply that it hasn't been studied. And that's why there's the difference about what the groups are recommending as opposed to what's on FDA labeling. Since this labeling which dates back to 2007, there have been multiple studies again that have showed the efficacy and safety of this approach. That's why the guideline recs have changed. And sort of in summary, yes, SMART therapy is off-label use, but it's very much supported by new evidence, and that's why it's being recommended. Just as a couple, how do you do this exactly? Sort of bookkeeping details. If you're going to prescribe SMART therapy, the typical rescue dose is just 1 puff, but the patient can repeat this after a few minutes if needed. And in fact, for 12 and olders, they can take up to 6 puffs over a fairly short period, but should not take more than 12 puffs over the course of an entire day. For 4 to 11-year-olds, that's more like 4 puffs at one time, up to 8 puffs for a total of a day. Much like you've got instructions for your patients that if you're using too much albuterol, you need to do X, Y, and Z, call me, go, whatever. If patients run this limitation of how much smart therapy extra doses they're taking, then they should be instructed to call or get further help. It's best not actually to even prescribe albuterol for these folks. As they get used to this change, are going to tend to grab that inhaler that they're most familiar with, which sort of undoes all the goodness of using the ICS-LABA as an inhaler. So albuterol is not needed. And in fact, if you've got a family calling you saying, I need albuterol, this isn't working, it's time to kind of bring them in. Maybe they need to go on to a different approach. But really the push here is to get families used to the idea of using the ICS-LABA for all of their needs. Just some additional asides about some new things in the 2020 guidelines. One of the things that is relatively new is the use of long-acting antimuscarinics, in particular Spiriva, which can be added to ICSs and even added to ICS-LABAs. As you can see from this chart for the 12-year-olds and over, this is more kind of a side recommendation for the step 3s and 4s, but comes into play as a definite recommendation for the more severe patients. These medications can also be used for younger patients. What's been another big change since the last set of guidelines came out is also the emergence of biologic therapies. It's hard to keep up with this, to be honest with you. They're a rapidly evolving group of medications that are targeted at specific anti-inflammatory markers within the inflammatory cascade of asthma. Different ones are used depending on whether you've got more of an IgE elevated or eosinophilic elevated. They're all injectables. They can be dosed anywhere from every 2 weeks to every 2 months, depending on which one you're using. They're extremely expensive. Right now, they're recommended for the most severe patients who are failing everything else. And as part of that, it's usually recommended as part of seeing a specialist to kind of make sure all the boxes are checked for everything else is being tried. And also, they're the folks that are going to be best able to help you sort of sort through and orchestrate which medicine they should start on and follow up and that kind of thing. Now, of course, changing medicine isn't the only way to approach a patient who's in poor control. We do want to review other things about what's going on with their asthma. Are they using the right technique with their inhaler? If the inhaled medication is squirted but doesn't land in the lungs, it's not going to work. So that's obviously very important. Adherence is an ongoing challenge for patients. And I want to point out that even in studies that involve adults, let alone kids, if you can get adherence of somewhere between 60 to 80%, you're doing pretty darn good. These medications just are very hard for people to follow through on. And I think there's a natural tendency for parents especially to not be thrilled with giving their what looks like a healthy child medication twice a day on a regular basis. It's just hard to stick with, and we need to be cognizant of that. We can go after reducing triggers if possible. I put the kittens up there to remind, I've never had much luck with pet extraction as an approach to reducing triggers. I have convinced some folks not to let the kittens sleep on their pillow anymore, but where possible, you can try and get rid of triggers, cigarette smoke, that kind of thing. The newer guidelines actually put a little less emphasis on some of the knee-jerk allergen stuff that we used to do, like, automatically having folks do mite covers for their mattress and pillows and that kind of thing. And more, if you're going to go this route, only go after triggers that clearly the patient reacts to in real life. And also, if you're going to go this way, oftentimes you have to go after multiple things all at once, that just going after one thing isn't as helpful. So the push to control triggers is a little less emphasized in the new guidelines. What is discussed is going after comorbidities. For some patients, treating their obstructive sleep apnea or their chronic sinusitis can be helpful. And actually, along these lines, if you're struggling with a patient, do consider specialist referral. Frankly, if they're not responding to good, solid asthma therapy, you do need to kind of step back and make sure you're on the right diagnosis, and a specialist can help with that. They can also help check back all these other things, and like I mentioned earlier, move the child on to biologic therapies if that's the appropriate approach. None of this is going to work. We can do all the right coaching and prescribing in the office setting that we want to. If the family isn't following through, or they don't understand what's happening, it's not going to happen in the home setting. So obviously good care is going to involve family and patient education. Here, it's particularly important, again, to make sure they know how to take their medication correctly. We recommend spacer use for all our patients, no matter how old they are. It's very easy to squirt and not inhale at exactly the right instant and end up with most of the medication on the back of the throat with the standard spray inhalers. We also find that folks, even if you go into elaborate degrees of explanation on the front end, the first time you prescribe stuff, if you recheck with them 6 months later about how they're doing it, there will be mistakes. So it's worth revisiting this intermittently to make sure families are understanding things, and don't assume they know anything. We caught folks who didn't know to take the cap off the end of the inhaler before they stuffed it in the spacer. We've caught folks using inhalers that have been at zero for who knows how long because they didn't realize it'll still spray propellant even when the medication's gone. It's always worth reviewing that stuff. Then the other piece is we really need to train our families up on how to spot when the episodes are starting and how to jump in quickly to sort of snuff them out before they turn into an emergency room event. And here's where that asthma action plan, as people have harped on forever, comes in. Sort of a one-page asthma game plan that, again, is going to help families identify which medicines they're going to use when, list key asthma symptoms, and should also include some explanation about if your albuterol is not working, then what do you do next? With hopefully some recommendations that are short of wait till you're really awful and then go to the emergency room. So that coaching around how to approach flare-ups is really important. The asthma action plan is nice because it standardizes this communication. It gives families something they can share with other providers, grandparents, and whatnot. Importantly, and I'll mention this again, it's also very helpful for the schools. And then finally, after we do all this stuff, we do want to see the patients back, right? So that we see whether they're actually responding to all this great advice that we've given them. So what are the challenges to providing this care? And again, I'm going to keep this really short because y'all know about this already. First of all, there's lack of patient contact. There's a bunch of kids floating around out there that aren't getting any kind of routine medical care. And basically, we're only touching them when they end up in the emergency room. That's a whole group. There's another group that may get some care, but they're not keeping those follow-up asthma appointments with any regularity. So it's sort of catch as catch can, whether you see if it's what you've been recommending is working. There's issues with getting the full story. Some families are sort of just assume that if their patient has asthma, they're going to cough and wheeze off and on, and that's just part of having asthma. So if you ask them, how's the asthma going, they're going to say fine. And you actually have to ask the specific questions to get the real what's happening out of them. Suboptimal patient medication use is anything from haven't been prescribed enough to insurance isn't covering it to they've run out of it at the pharmacy. I think Kellen went into some details about how to deal with that the last talk that we had. There's also problems with families not taking it, et cetera, and so forth. So that's a big component of challenges to providing care. Limited office time. You don't have that much time to run through all these things. And then I'll throw out there that medication prescribing ruts, I think, are a little bit of a problem. We get sort of settled into using a certain approach, and it can take a big nudge to say, we got to try something different with this kid, right? And especially a nudge also to start using something that's unfamiliar, like smart therapy, to sort of up the game a little bit. So what are some office strategies to overcome these? And these, I'm basing this next little part around QI work that we've done with the pulmonary or the primary care network clinic at Nationwide, where they deal with these same, short periods of time, poor patient follow-up, et cetera. And I'm going to start off by saying that we all know that we're supposed to exercise on a regular basis. Actually doing that is a different story, right? It takes a little bit more effort. You got to get in good habits. You got to establish patterns. The same thing is true for asthma care. All of the stuff that I've just told you, maybe with the exception of some nuances around smart therapy, you guys already know this stuff. The challenge is actually operationalizing it. And these are some things that we found that helped get this operationalized in the primary care network. First of all, flagging patients' charts so that it's very obvious when they come in the clinic, this is one of the asthma kids. You don't have to notice it somewhere buried in the list of patient problems. We established a goal, aspirational goal, of trying to use every time a child showed up for anything and they had an asthma diagnosis to sneak in at least a little spot check on how their asthma was doing. And this was partly shoved by that issue that patients don't come by all that regularly. So you got to catch them when you've got them in your clutches. Pre-visit brief symptom checks were very important in sort of getting us off the ground. And what we used at Nationwide Children's was the asthma control test. There are other control questionnaires out there that can be used, or you can simply have a rule of twos type questionnaire. Importantly, these questions are presented to the family and they get a chance to answer them before the provider enters the room. And here's where you're enlisting your support staff, which gives them a role of this, and also, frankly, just sort of spreads out the burden of this care a little bit, so it's actually achievable as opposed to trying to take it all on just on the provider's shoulders. Once this was done and an asthma control test is there, then the next push was really that it be documented, that I get some evidence that you actually looked at it and wrote down the number, and then even put a stake in the sand about whether you judge the patient is controlled or not. Now, if their ACT looks great, you might move right ahead and say yes. If it's not so great, you may ask some additional follow-up questions, but you got to make a call, controlled or not. And then we added a drop down that said, if they're not controlled, pick something that you're going to do. Now, the something that you might do could involve review correct technique or reemphasize adherence. But we also stressed and challenged folks to half the time, at least, step their therapy up, pick a different approach out of the options that we have. And that this piece, as we added it, was the one that had the most impact on actually improving asthma outcomes. It's that nudge to just try something different. Obviously, all of this, it's important that family understands, especially any changes you're making. So asthma action plan use is important. And then also we were able to include in our automatic information that came to the provider's forefront, community resources that they could tag into as another option for what could you do in terms of doing something different for a patient. Quality improvement techniques that were used as part of rolling this out included, again, that concept of having the whole team be part of it, not putting the burden all on one person's shoulders, incremental changes, monitoring. So it's not good enough for everybody to sort of say they're doing stuff. It's important to actually check to see if it's happening. And that doesn't have to be every single chart. It can be a little sample, 10, 20 charts every couple of weeks, just a spot check, right? And also give feedback then about whether, yes, we're seeing this happen like it's supposed to, yay, or not so much. We need to regroup and try and figure out how can we make this more of an automatic happening. In terms of some more details about all that, I do have at the end of the talk a reference that you can look up that was recently published in Pediatrics about the primary care network experience. In terms of community resources, there's a variety of programs now that exist to support asthma care efforts. We're lucky in Ohio that we have so many pediatric hospitals, and I think each and every one of them has their own asthma things that they're helping support. I encourage you to check with your local pediatric hospital for things that you may be able to plug your patient in on. There's also websites with things that help with education and whatnot, both at the Ohio Department of Health as well as the American Lung Association. And with that, I will finally get to the part about talking about schools, because schools have been one of the really important things I think that we've been able to partner with in our efforts to improve our asthma kids' outcomes. You know, as I said, even if we're doing perfect care in the office, and there's always room for improvement there, but even if we were perfect, the patient leaves our care and they're out into the world. And here is where the schools can help us, along with relying on parents and caregivers to follow through once folks have left our immediate orbit. The way that we've approached partnering with schools at Nationwide Children's has been through a program called school-based asthma therapy. This is a somewhat time-intensive approach that really is meant to target those really high-risk, poorly controlled patients that you're worried about that are ending up in the emergency room at an excessive level or frightening you with ICU stays, that kind of thing, as well as are impaired just from their day-to-day functioning at a level that even the school nurse can pick up on. This program acts as a bridge to sort of combine efforts between the providers, the families, and the school nurses, with a real focus particularly on improving controller therapy consistency. And at its core, what I think the most important piece of the intervention is that these kids get school-based, directly observed controller therapy, typically once a day. So it's 5 of their 14 doses out of the course of a week. But that consistency helps set them up for success. This does require that they have a controller inhaler and a spacer at school as well as at home. So there's some logistics around arranging that. And it also requires that the school staff, and nurse usually is who this falls to, help set up a routine way for the child to come get that medication. If they're not taking it routinely at home, they're not going to automatically remember to take it at school. So there is, as I said, this involves some effort. And so we're really saving it for those worst kids, but for those kids, it can be very effective. The logistics of doing this can range from the very basic to what we've now, after 10 plus years, developed, I'll call it a deluxe system at our local neighborhoods. So basic, and I did this even before we launched a formal school-based program, was if you are out in a small community and you've got that one patient that is just scaring you to death, reach out to the school nurse and talk to them and see if they would be willing. If you can figure out a way to get the controller to them, could they manage to pull this off in the school setting? On a one-on-one basis, this can be effective. It's not a great way to run an entire raft of patients, but for those single really needy ones, if you don't have a program in your local school, you can set this up via this sort of opportunity. A more deluxe program is, as I said, what we now have at Nationwide Children's. We are up to over 850 students in over 300 schools, to give you an idea of the size of our program. This involves now a centralized coordination team that helps with that communication between schools and nurses and providers, and for us also our pharmacy, to make sure prescriptions get routed properly, to make sure everybody's on the same page with the patient, to help relay, hey, the school nurse is saying that this kid's in her office all the time needing albuterol. I'm not sure what the family's telling you, but this is what they're seeing at school. Those sorts of communications, we can help optimize that. We help make sure that the kids get their follow-up appointments at least made and reminders. We can do some intermittent, at school, have the child fill out an asthma control test at intervals. So there's a lot of extra gingerbread about this, but at its core, the key thing is still that we're getting controller medication at school, and the school nurses are doing the lion's share of the work of making sure it's administered at least once a day. Our use of our centralized pharmacy allows us to set this up as a delivery program. We deliver both to the patient's home and to school. If you're thinking about trying to do something like this and you're in a system that's 340B eligible, the medication savings around the 340B can be a helpful source of financial support for rigging up the system, by the way. In any case, what we've seen, and not only have we seen it locally, but this type of program has been set up in multiple places and published on across the country, is that we've seen important improvements in parameter of impairment and risk. In the neighborhood of emergency room and acute office visits and urgent care visits dropping by 50%, hospitalizations dropping by about 50%, ICU stays dropping by 75%. We also see a rise in the percentage of kids that are controlled by looking at their asthma control test, and also by when they go into the clinic, whether their doc or nurse practitioner who is seeing them also agrees that they appear to be in control. The nurses at school like this because they can sense that the kids are not stumbling into their offices needing acute therapy as often. So they're willing to do this work because the squirt on your way in the morning is a whole lot less stressful and fulfilling than dealing with that child who's stumbling in distress. And then anecdotally, we also hear about kids who are starting to remind their families at home on the weekends, hey, I'm supposed to take my medicine now because they've been doing it at school, and also start to do a little bit better job sometimes in their schoolwork. Now, what have I learned as part of being involved with this? When we first started this program, it actually was me. I would go out to the schools personally and do the paperwork and make sure they had everything they needed and drop off the meds. And it was helped me get a real education into how school nurses are operating. I will always remember the one school I went to visit, and I walked in and the school nurse was busy dealing with, in one corner, a child who wasn't in our program, tripoding over, retracting, sucking on a nebulizer, another kid over in the bathroom vomiting, and a third kid coming in with a skinned knee. And this nurse was very calmly sort of dealing with all this. I mean, they're busy, but they're also, of all those patients, the one that scares them is the kid who can't breathe, right? This is true when there's a school nurse there. Many schools do not have a school nurse constantly present, so it's school staff. It's the administration secretarial staff. They're being confronted with this child who can't breathe. They really, and they don't have, they can call the emergency room, but otherwise they are dealing with kids that in many ways look just as sick as some of the kids we see in our ERs. So they're on the front lines. And that's part of why they are willing and eager to help us with some of these programs. The other thing, as illustrated by what I just said, is school nurses are busy. As time has gone by, school nurses have more and more kids with chronic illnesses, and they're juggling more and more just ongoing medical needs, diabetic kids and insulin pumps and whatnot, in addition to the asthma kids. They also have more and more things that they are required to do as far as keeping track of whether folks have their vaccinations or what paperwork's been done or whether this assessment's been done or that. So when we go to them and ask them to be involved in a program or just a one-on-one patient, we do need to be cognizant and aware that they're crazy busy. And the more that we can take stuff off their plates and get them just to do the stuff that only they can do, like administering the medicine once a day, the more that an interaction with them is going to work well. As part of this, they really appreciate very clear communication about what it is that we do want them to do. And here's where the asthma action plans come in. Schools love to have asthma action plans on their patients. It helps them understand how severe the child's asthma is by looking at how much controller stuff they're on and to understand what should be happening at home at least. It helps give them clear instructions about what to do when the child flares. This is going to get even more important as we do start to have more kids who might not be using the routine albuterol and instead might be using an ICS-LABA. And so they're clear on that. They also welcome help from providers around education just in general. And this can be for education for the school nurses on sort of their update sessions that they have, or sometimes help teaching staff members at school, if they're not going to be there all the time, how do you deal with that acute asthma patient? And the answer is not give them sips of water and some other things that might surprise you. So they welcome our help in kind of helping put out that education. One potential thing that you may bump up against if you're working with schools is issues around patient confidentiality. So from our angle, we have the HIPAA regulations, which actually don't limit us much. So calling a school nurse about a patient that you're taking care of to discuss how that patient's doing at school, what therapy is being given, what's working, what's not, is just as covered because you both are taking care of the same patient as it would be to call the nurse at the hospital and find out how your inpatient's doing. So we don't need extra things signed to call a school nurse and talk to them about a patient. Little bit different from the school nurse's point of view. So the Family Education Rights and Privacy Act is what covers them. And it does not allow school nurses to sort of randomly pick up the phone and call the student's physician without specific written consent, unless the child is having significant threat to health and safety, which I would suggest a child tripoding in the office, that counts. Or if the nurse is verifying, and here is the concept that you've reached out to them, they don't need special permission to talk to you about stuff that you're calling to verify, or to find out. So what this means is flow of information wise, we can easily call school nurses and talk to them. There may be a little bit of hesitancy or rules that need to be checked on as far as them randomly reaching out and calling you. And so that's why we may discover that kids are having terrible problems at school, but nobody's called their physician, right? Some schools actually will build in this written consent into the consent that goes with signing that they're to receive albuterol or some other medicine at all. So district-wise, there may be different rules or already solutions in place that'll be important to get aware of in your local community. So just sort of to sum up, school nurses, untapped resource. They are present for a significant portion of child's waking existence. They may be aware of symptoms, more symptoms than the family was, especially like symptoms around exercise and that kind of thing. We have a lot of patients falling through the cracks. These may be the only health professionals that are aware of these kids' problems outside of those emergency room docs, right? So in fact, what we have found is we've set up a way that allows school nurses to refer to our program. Over half of the referrals that we get into SBAT are these kids who are falling through the cracks or symptoms are not as obvious, when talking to the family or as they are to the school nurse, and really helps us pick up a lot of kids that otherwise would be missed. School nurses are often eager for our help and to help our patients. Partnerships, again, require that mutual respect, honoring busyness, and also the need for good communication. So summary, high quality asthma care. First off, y'all know what high quality asthma care is. I reviewed at the beginning of this, but these are lessons that we've heard many, many times. The challenge is to establish a consistent routine, particularly for assessing asthma in the office, at least in a quick and dirty way for any time you get the opportunity. And then a push to really address the asthma. And I'm going to emphasize, if it's broke, fix it. So, if you're tempted to say, well, they had a cold last week, it's probably okay, but if you're finding yourself with kind of saying, I'm just going to stick with the current thing because this other thing, maybe, it'll get better on its own. If this is the second or third time you've done this with this kid, time to get into your toolbox and do something different. And that toolbox has changed. And importantly, the smart therapy is probably the biggest new thing on the block along those lines. Schools are our allies. We may need to reach out to them to establish those alliances, but they really can be great partners in this work. And particularly for our really worrisome kids, they are eager to have our help and worth taking advantage of. And with that, I'll stop and we can tackle some questions. And here's some additional references, by the way, for some of the things that I've talked about.
Dr. Allen, thank you so much for the good information. There's positive feedback coming into the chat, but no questions yet. Feel free to type something in or unmute yourselves and ask directly.
Hi, I just wanted to say that was an awesome talk. Thank you so much. Can I ask a specific question about the school-based care? So if they don't have school nurses, which I feel like we tend to see a lot, or like one school nurse covers maybe like 3 schools, do you find that you've had positive rapport with getting like school, like usually there's a health administrator or someone who's like the designated person to give the medication?
Yeah.
Have you had a positive experience with that?
We have, particularly if there is a designated, you figure kids are getting medication at school. They get ADD medicine at school. There's other things going on at school. It's not like this is a bizarre request, right? I think this is where you're very strategic in how many children, you ask a school system to take care of. Many of the schools that we are involved with may have only 1 or 2 kids that are doing this. We also have some nurses who are all about this program and have over a dozen. I have this, next. I don't know what they do in the morning, but you do want to temper how much you do this with what kind of resources the schools have. We have had good successes in schools that have at least some school nurse presence, and particularly if they've formalized who the medication person is. We've had, sometimes there's other designated drivers or designated med. We can set something up for an individual child, again, kind of with a one-on-one approach. We charter schools that have no school nurse sort of connection have required more intensive coaching by our folks, and those systems are a little bit more difficult to pull this off on. Not impossible, but they really do need help with getting into rhythms of how to get this done.
Great, thank you.
And by the way, just a plug to put in, this is a nice example of where if we ever have the opportunity to champion for school nurses, that they have more school nurses to help with all these kinds of things. This is a good example of why that's important.
A good comment in the chat around, thank you for explaining that school nurses can talk to providers. Is this an identified gap or maybe a challenging space, having that initial conversation? What would you recommend?
I don't think there's a challenge when we call the school nurse. The more I think it helps explain why school nurses may be seeing children with problematic issues and have a sense of hesitation about cold calling us, that opposite direction of flow. And so, if that seems to be a big problem, it may be helpful within the school district to sort of clarify, what are we going to call the rules around this? I mean, we have found as we've done this program that nurses have been, we get consents and stuff like that around rolling this SBAT out. So we take care of those needs, but it's just something for us to be aware of as providers, of why the flow of information may feel a little disjointed a little bit, and that there may be a need to actually just have the family sign something so everybody's happy, kind of stuff. But again, there should be no issues with, I'm calling to find out if my patient's using albuterol at school and how often they're using it. That's specific discussion around a specific topic that you're asking for the nurse's input, and their FERPA laws should not prevent them from being able to talk to you about that.
Thank you.
Mhm.
Do you anticipate Symbicort being staffed at schools for those on SMART?
Yes, we do. And we have, I think at last count, about 50 kids, not a huge number, but we have kids within our SBAT program that are using the SMART therapy at school. Part of the reason I brought up the FDA business is the school nurses that were asking about that. And they had some hesitation, and we had to actually a whole talk for them about why we're doing this, et cetera. But I think it's that mutual respect thing. You explain to them exactly why this is happening and who's recommending it and what the studies have shown, and it has smoothed going forward with it. But again, they're used to knee-jerking grabbing the albuterol, so that extra education for them is going to help the partnership.
Yeah, I would echo that. I had a patient who I sent their action plan in with our SMART regimen, and actually they and it was hard because unless they ask, I don't know who to call. But it was the same thing. We just had to educate and give information, and everything went really smooth after that initial period.
Right.
Any other questions from the group?
All right, I left a lot of time for questions. Sorry about that.
Oh, that's good. I do have a thank you to you. Thank you. This is very informative. I'm in healthcare, not providing patient care, but ever since my daughter has been diagnosed with asthma, I am trying to learn more and just wanted to be an advocate for families and community. My daughter's preschool does not have a nurse, and I had to help educate a lot. She has cough with asthma.
Yeah. We haven't quite gotten to preschools yet with the SBAT program either, by the way. Often there's not consistent enough attendance, and they're all different, and trying to figure out who's going to get the medicine is a little crazy. But it is a good example of where, it may even need parent triggered, or using some of those resources at the websites I provided, education resources provided to the folks at school about, again, what to look for and that kind of thing, when to treat. I think the need to treat persistent coughing with asthma rescue therapy is one of the harder, folks are pretty easy to convince that wheezing deserves that. But that cough is often the first symptom that starts before it gets to frank audible wheezing, and that's where you want to be able to jump in. So
What steps do you take to educate families for summer in your SBAT program? Good question.
yeah, we part of our process in the summer involves a lot of our patients get to their docs for their routine appointments in the summer. So a lot of our interactions with them are around that. We also make an effort to get their leftover controller from school home with reminders about they're supposed to keep using it, and do they need any, other kind of refills in the summer. I have to admit, our contacts with the families are less frequent through the summer as they are once we get back into the school year.
Is there a beginning of school year kind of effort to bring everybody back that was enrolled before?
Yeah, we actually start calling families about whether they want to re-enroll in the program, even in the spring of the year before. As everyone knows, one of the most vulnerable times for asthmatics is that initial fall season. So as much as possible, if we're going to have kids continue in the program, we try and get them identified and their meds at school in advance of them arriving at school. So that they can start up as soon as school gets underway, and we found that very helpful. Honestly, one of the challenges we've had that delays that is the need to have families sign off on the permission slips that schools provide for using the medicines. And so if you're going to work with schools around this, discussing how can we do this to make sure it happens. Some school systems have systems that work very well, some others not so much, and there can be delays. And so a lot of setting these things up is logistical challenges, and each system is going to be a little bit different, just like each of your offices is a little bit different in what you're going to do to overcome them, but it's worth the effort.
Very good information. Keep the questions coming, but I will kind of give you the CME information slides. Dr. Allen, can you give me the next slide, please?
Sure.
Thank you. Go back one, if you don't mind.
There we go.
Thank you. So around the CME and MOC Part 2 evaluation credit information, I will be sending this out via email, so you'll get another email from me. Once you fill out the necessary forms, you will receive your certificate of completion within 10 days. And anything presentation related or evaluation or credit related, please email me with any questions. And one more slide, please. So this is the second of 3 asthma training series. So we'll have one more session, session 3. This is coming up on June 10th at 12:30 p.m. We'll be hearing from Dr. Beck around asthma, health equity, and justice. There's a lot of you on here that have signed up for all 3 sessions, and some have signed up for one-off sessions. But if you want to sign up, you can scan the QR code right there or email me with registration information or any questions. Okay, last call for anything else from Dr. Allen. Okay, I can give you a minute back. So Dr. Allen, thank you so much for your good information today. Thank you everybody for joining, and we will talk soon. Have a good week.
Thanks, everyone.